Thank you. Thank you, Dr. Malik, for putting up weird cases, and then we'll be moving on to one of the more routine and common causes. So nothing too special there, although it's a very important topic. So, of course, we're talking about occult atrial fibrillation. I have one disclosure. I'm an adjudicator for cases for the BASE trial, which is a biomarker trial, somewhat relevant to the topic, in that it's looking at biomarkers to detect the etiology for cryptogenic strokes or strokes as they come in. So why do we care so much about occult atrial fibrillation in stroke? Well, atrial fibrillation is extremely common within the United States. Over 2 million patients in the US have atrial fibrillation. And then we kind of come to the rule of thirds, where about 1/3 of all AF patients are yet to be diagnosed with that condition. We also have about 800,000 strokes in the US per year, with about 1/3 of those being of an unknown cause. So what that basically means is that around 250,000 patients a year will be told they have a stroke, but we don't know why. That's somewhat disconcerting from the patient standpoint. And then we do know that AF is very important because it essentially increases the risk of stroke by a multiplicative of 5. So it's a very important cause of stroke. So how did we kind of come around to this, well, focus on cryptogenic stroke and the occult AF? Well, you go back to the WARS trial, which is warfarin versus aspirin, and one of the subgroups, they looked at various things, and then they looked at the cryptogenic cohort, and within this one cohort, there was about an 8% reduction in the risk of stroke. Not statistically significant, because this was not really powered to find this difference, but it begged the question, what's so special about the cryptogenic cohort? Why do they respond to anticoagulants more than the other conditions? So we want to start to look at how we can identify paroxysmal atrial fibrillation. So when a patient comes into the hospital, what's one of the first things you do after you've potentially treated them with TPA and other things is you get an EKG. And that admission EKG can diagnose up to 7.7% new cases of AF just with that admission EKG. In some places or situations where you may not have the opportunity for telemetry, perhaps this is a stable patient who's been diagnosed as an outpatient, you can actually do serial EKGs and capture another 5.5%, 5.6% of AF cases just by doing EKGs. And with the EKG, there's a lot of information that you can get from that. And this is one of the highest quality exams that you can do from this category, because you can see multiple channels. You can look at the P waves. You can get very detailed information from those things. And those things can actually help you predict whether or not they're going to go into atrial fibrillation. And the next thing was, well, they get admitted, and for the most part, they're put on telemetry. And basically, the guidelines suggest that all stroke patients should have at least 24 hours of cardiac monitoring, regardless of what type of stroke it is. And that, by itself, will detect another 7%. And that during telemetry, one of the things that we don't often notice is you're in the room with the patient and you're looking, and yeah, it's normal sinus rhythm, but there goes a PAC. There goes a PAC. These are relevant. We think of PACs as kind of precursors to paroxysmal atrial fibrillation or triggers for AF when the PAC perhaps occurs in the atrial vulnerable period. So you get more cases that way. And then moving forward, another option is Holter monitors. Some places don't have inpatient telemetry or EKG monitoring, so these patients should get at least 24 to 48 hours of Holter monitoring. But with Holters, you can add another significant percentage of AF detection. Holters are also great because they can even calculate for you how many PACs they've had. And the number of PACs is very important when you're trying to decide whether or not somebody is at high risk or not for atrial fibrillation. A couple of studies, one that looked at greater than 70 PACs per hour, another one looking at greater than 1,500 PACs in a 24-hour period, was significantly associated with high rates of AF in the future. So you get a lot of information from that. And then Next is event recorders, external loop recorders, and things like that. And they got another kind of 7.5% or so. Some of the newer ones, now they can go on for longer periods of time, up to 30 days or so. And then we'll talk about a couple other more specific ones going forward. So the next one is MCOT, or mobile cardiac outpatient telemetry. And this one has, from these types of monitors, have shown a little bit higher detection rates, up to 25% or so. When used for 21 to 30 days. I want to talk about this one a little bit because this is kind of how I got interested in atrial fibrillation and cryptogenic stroke. But in 2008, Atrial published 56 patients with cryptogenic stroke and a detection rate of 23% for MCOT monitoring of 21 days. So that's a really good percentage, but that's only 56 patients. At a time that I became interested in this, we were doing this routinely on patients, and I said, why do we do this? And it was, well, because of this one study, a study of 56 patients that was retrospective. Like, well, maybe we should look at that a little bit more. During the time we were looking at it, another one came out, again, relatively small, 62 patients, but again, a really high rate of AF detection. So this became a much more important thing in the detection of a cause for cryptogenic stroke patients. So this leads me to the project that I did as a fellow. When I came up with the idea of doing this, which was a little bit of a rehash, my supervising staff said, don't do that, it's not worth it, you know, there's nothing. So like any good fellow, I didn't listen to them, and I went ahead and did it anyways. It turned out well, you know, it was more than it was you know, a great study or anything like that. It was just good timing. I think people were saying, yes, we need more of this. And I got to meet Jose Biller, who's in the picture right there. And that was for the mobile cardiac outpatient telemetry. We had 156 patients, a little over 17%, like 17.5% detection rate for AF. And it kind of led me down this path of interest in this topic. So here is what the mobile cardiac outpatient telemetry unit looks like. So when you tell patients about what they're going to have to wear and things like that, you say, you put on this monitor, you're going to look like this. You tell their wife, they're going to look like this as soon as you put this monitor on them. Additionally, so just kind of new advancements. These monitors are changing constantly, and in this particular MCOT monitor is going through some other upgrades as well. And there's more of a patch based, so it doesn't have all the leads, and the thing hanging around his neck is much smaller. So they're constantly evolving, and so we'll keep an eye out for those evolution and things like that. So based on Atrial study and my study and BOT study and a bunch of other retrospective studies looking at non-invasive external cardiac monitoring, prolonged cardiac monitoring, even though there was nothing prospective or randomized. In 2014, the American Academy of Neurology, followed by the American Heart Association, American Stroke Association, put out guidelines recommending routine use of prolonged cardiac monitoring up to, say, approximately 30 days or so in cryptogenic stroke patients to look for occult atrial fibrillation. So they identified the importance of this condition. But again, it was basically expert opinion and non-randomized controlled trials. If they had waited a few months, there was these two trials, the Embrace trial and the Crystal AF trial. These were the first two randomized controlled trials looking at this. So what they considered at the time, comparing it to usual or baseline monitoring, which was only 24-hour Holter monitoring. So it wasn't comparing to the other prolonged external monitors, but comparing to 24-hour Holters. So the first one was the Embrace trial, and the Embrace trial was like a belt-like external event monitor. They detected a little over 16% at 30 days versus 3.2% with a 24-hour Holter. So again, a very good yield with this device. And then the Crystal AF trial, this is the insertable or implantable cardiac monitor, detected about 9% at 6 months. This increased to about 12.5% at 12 months. And then if you were able to wait 3 years to get the results, you got up to 30%. So this was really increasing the yield of detection. Now, you see there's a little bit of a discrepancy with 16% at 30 days, and then, kind of it would take about 1.5 years, 2 years, based on the numbers to get to that percentage with the implantable. There were some differences between the studies. Patients were a little bit older in the Embrace trial, things like that. There was another study for the implantable monitors that kind of risk stratified, and I'll talk about risk stratification a little bit in a minute, but, taking people who are considered at a little bit higher risk for AF. So obviously, not all of these patients have atrial fibrillation that you're looking for. So there's got to be some maybe signs or risk factors that put people at higher risk than others, and that's really useful information. So in that study, when they looked at high-risk patients, they were able to get to that 30% mark within about 6 months or so. Here are some of the other cardiac monitoring options. There's a lot of things, like I mentioned, for the EKGs. You get a lot of information from that. I'll list some of those other benefits to the things that you can see, especially the P wave. And the Holter monitors I mentioned, the PAC counts and things like that, atrial runs, all of those things, the supraventricular ectopic beats, these are all important in determining the risk for atrial fibrillation and whether or not you proceed with further monitoring. Then there's some newer 14-day compact monitors. Here's a couple of the examples. One's kind of a patch-like. The other one is just kind of a discrete, small, with a couple of leads. And then there's the loop recorders and event monitors, and like I mentioned, the MCOT and the insertable cardiac monitors. But the keys to success is to have a device that's going to give you quality EKG tracings, garbage in, garbage out. You're not going to get a good diagnosis if you can't see the tracings. You want to have, the device should have quality automated AF detection algorithms. So now they've gotten much better at detecting atrial fibrillation, but there's still differences between different devices, and you want to make sure that they have gone through some sort of vetting and things like that to make sure that they can actually detect reliably, since these are asymptomatic episodes. And then you need to know that they're going to be able to monitor for a long enough duration. So what we've seen is, from our study and the other studies, is that 7 days, 14 days, 21 days, 30 days, it's kind of a linear line where you're continuing to get AF episodes throughout that time period. So you really need to do at least 21, 30 days or so. And then perhaps at that point, risk stratify and decide whether or not further monitoring is warranted. So this is kind of getting back to the refining our search and using all the information that this ambient information that we tend to ignore. We don't take all this stuff into consideration. Obviously, age is a big factor. So as people get older, the risk of AF goes up and up and up. The PACs I mentioned on the EKG, if in our study, if somebody had a PAC on their baseline EKG, they had a 60% chance of having AF detected on monitoring for 21 days. And that's just because, if they're having enough PACs to have one randomly on your EKG, they're probably having so many that they're going to end up having AFib because they're at that higher risk. The Holter monitors are really nice, as I mentioned, because you get a lot of information on those. Then the P-wave morphology, so you can see left atrial dilatation based off the P-wave. There are other things like P-wave inversion in the terminal force in the V1 lead. So if you're good with EKGs, cardiologists, other internists, or whoever may be good at looking at these things, you can use these, and they will predict whether or not they're at high risk for AFib. There's the P-wave max duration and the P-dispersion value of greater than 40 milliseconds. These are all risk factors for AF that most people don't know about or think about. Another big one, and we're doing with the residents a review, we were able to utilize the electronic health record system and pull data from 8,500 patients, looking at their left atrial size from normal, mild, moderate, and severe, and you see very straight correlations with the size of the left atrial dilation to the likelihood that they have AF. And those with severe left atrial dilatation have about a 50% chance that they've already been diagnosed with atrial fibrillation. So what about the other 50%? So if you look at patients that have a dilated left atria of any size, a little over a third of them have been diagnosed with AFib, but what about the other 2/3? We know that they're probably at very high risk, so these should be people that we look at. And I have gone against the guidelines, looking for atrial fibrillation in somebody who has a lacunar infarct. That's not what we're supposed to do, but I'm sitting there and I'm seeing PACs, and I see that on the echo they got a moderately dilated left atria. I know they probably have. I've done it a few times, and sure enough, we find atrial fibrillation. So we could even start to move away from just looking at cryptogenic stroke patients and move this to even primary diagnosis, primary prevention for people who are at high risk based on echoes and EKGs and things like that. And that's one of my interests is going forward. There's other things that you can find on a TEE. This is things like left atrial appendage smoke, emptying velocity, the morphology, all these things that increase the risk or change that. And other things are the biomarkers like the N-terminal pro-BNP. That's a big biomarker. For treatment, aspirin 20%, warfarin reduces by 60%. It's a kind of a miracle drug. So what is this miracle drug? Well, it's a pesticide so for rats and mice. And oral prescribing practices are abysmal, and adherence is even worse. So it's kind of the nightmare drug because of all of its issues. And yes, it's rat poison, and that comes up repeatedly. And we have patients who say, I won't take that rat poison. Literally come into the office and say, I won't take that rat poison. So you have alternatives. These DOACs that we've heard about, they're great. They have a lot of options, different doses and things. They have some limitations, but they have a lot of benefits as well. You still get people that say, well, no, I don't care about the Coumadin, I don't care about the DOACs, no, thank you. Well, how do we convince them? Well, you take studies, the Averroes trial, apixaban versus aspirin, and this showed reduction in stroke, no major bleeding increase or ICH, and then she comes back at you and she's still there looking at you, like, So I've bled before, never again. So what alternatives do you have? Left atrial appendage occlusion. 90% of thrombi occur in the left atrial appendage. You can, and our cardiologists will tell you, they basically shove this thing in there, block it off, and prevent strokes. And then there's the lariat procedure, which they may mention as well, but just wanted to throw that in there. All done. Thank you.